Hi, my name is Dr. Brittany Singleton, and today I will be presenting to you Module 8 of the COVID-19 Vaccination Certificate Program, Storage, Administration, and Post-Vaccination Considerations. It will be broken into 3 parts, and this is Part 2 of 3. As I said, this is Module 8 of the 11 webinar series. Please tune in to the other modules for your CE credits and for your certificate with full and final completion. I have here my contact information, including my email address. I would like to say that I have no relevant financial relationships or commercial interests to disclose. This activity, Parts 1, 2, and 3, are approved for 1.5 contact hours by the Accreditation Council for Pharmacy Education. Today, we will generally cover learning objectives 3, 4, and 6. So, we will be reviewing appropriate vaccine administration techniques as well as OSHA requirements, recognizing the common side effects and rare adverse events associated with the COVID-19 vaccines. We will also be identifying the important considerations when prioritizing groups for vaccination, scheduling patients with increased precautions or contraindications, and when scheduling follow-up doses. I want to remind you all that this is rapidly changing information, and this presentation is current as of December 15, 2021. COVID-19 vaccine administration. As we begin this conversation, I want to highlight some important regulatory aspects of vaccine administration. I would first like to highlight the Federal PrEP Act, which stands for the Public Readiness and Emergency Preparedness Act. This act enables the Acting Secretary of the Department of Health and Human Services to make a declaration in response to public health emergencies. One of the functions of the most recent 2020 PrEP Act declaration was to expand the pool of qualified people who can become vaccinators, and this was done to beef up the healthcare workforce in order to fight the pandemic. In relation to pharmacy, it gave extra vaccination-related protection and, in a roundabout way, authority to pharmacist interns and technicians. So in this case, pharmacist interns and technicians may be authorized as vaccinators so long as their supervising pharmacist is readily available to them and they are giving vaccinations that have been FDA authorized or licensed and giving those vaccinations according to the ACIP recommendations. Just as a reminder, ACIP is the Advisory Committee on Immunization Practices. As immunizers, they must complete an ACPE-approved immunization training program with a practical component, as well as maintain a current CPR or BLS certificate. Now, the PrEP Act is a federal act, and as far as the state and state boards of pharmacy are concerned, they have been acting in conjunction during this state of emergency, the federal and the state governments. During the pandemic, the Louisiana Board of Pharmacy has released guidance relating to several things, including COVID-19 vaccine administration without a prescription order or order from a prescriber, or extending expiration dates for certain credentials and medication administration licenses, or the allowance for healthcare professionals from other states to practice here. Now, normally, pharmacy interns are authorized to perform the tasks of a pharmacist as long as they're under the supervision of the pharmacist preceptor, so that's typical. I have not yet seen an explicit approval from the Louisiana Board of Pharmacy for technicians to be sanctioned as immunizers by the state. However, they have not been forbidden from immunizing either explicitly. So I do believe at this time they are able to complete the appropriate training and apply for medication administration numbers. All immunizers must, of course, maintain their BLS training and complete a minimum 2 hours of ACPE immunization-related CE within their licensing period. Now let's move on to OSHA regulations. The Occupational Safety and Health Administration is a subsidiary of the Federal Department of Labor, and it sets enforceable workplace standards. The most important standard set by OSHA relating to vaccination activities will be the bloodborne pathogen standard. This standard seeks to protect those in the workplace from occupational exposures to hazardous bloodborne pathogens such as hepatitis B and C, HIV, and some others. I would like to discuss some aspects of the bloodborne pathogen standard, including exposure control plans, employee vaccination and training, engineering controls and safety devices, workplace practices and PPE, and post-exposure evaluation and follow-up. A critical aspect to the bloodborne pathogen standard is the exposure control plan. Employers need to identify their at-risk employees or job positions and come up with procedures to reduce, manage, and evaluate exposures, as well as a plan to maintain compliance with those procedures. The exposure control plan should be reviewed and updated annually. Another aspect that we may be familiar with is hepatitis B vaccination. All employees with potential exposure to blood or other potentially infectious materials should be offered hepatitis B vaccination free of charge, although employees can decline this offer. Employees should be trained regarding the exposure control plan at initial assignment and at least annually, and this training should all be documented. A large part of reducing pathogen exposures are engineering controls and safety devices. There are methods to prevent or reduce needle sticks. Some examples include the use of the sharps container after medication prep and administration. Also, the use of a safety cap syringe and needle set as shown in the image here, where there's a plastic safety shield to flip down and cover the needle after an injection. There are also retractable syringe and needle devices which pull the needle into the barrel of the syringe immediately after an injection, as shown here. The Needle Stick Safety and Prevention Act of 2020 requires that organizations evaluate their safety devices every year and consider implementing any new or safer technology to protect workers. This evaluation and device selection has to include non-manager level frontline staff who are at risk for potential injury or exposure. Regarding workplace practices and personal protective equipment or PPE, an important policy would be the use of universal precautions when handling potentially infectious materials. The concept of universal precautions requires that we treat all blood or other bodily fluids as if it is infectious. The entity should designate hand washing and hand sanitizing procedures as well. PPE or personal protective equipment such as gowns, gloves, face shields, etc. should be provided, and employees should be trained on how to use them appropriately. There should also be provisions for post-exposure evaluation and follow-up. This means that if an injury has occurred, such as an accidental needle stick, that it is documented in the sharps injury log along with the circumstances surrounding the event. Testing should be done on the source individual's blood as well as the exposed employee's blood to ensure there was no transmission of bloodborne pathogens. A medical evaluation should be provided to the employee, and they should receive post-exposure care and sometimes medications when necessary. Now, I want to come back to the specifics regarding administration of the COVID-19 vaccines. We have already discussed each of the 3 vaccines in detail during part 1 of the module. When ordering and receiving shipments of COVID-19 vaccines, you will also be receiving ancillary supplies. These ancillary supply kits contain almost everything you need to administer the vaccine. They should contain various needles between 22 to 25 gauges and 1 to 1.5 inches, along with syringes, alcohol prep pads, surgical face masks and face shields, an administration guide, and our familiar COVID-19 vaccination record cards. For vaccines that require dilution, the diluent vial should also be included. Some of the things that may not be contained in your ancillary kit are sharps containers, gloves, and bandages or band-aids. I have here the CDC recommended PPE for COVID-19 vaccine administration, which definitely includes a face mask and includes eye protection in some situations. You may notice that gloves are not necessarily recommended or required for intramuscular or subcutaneous vaccinations. However, It may be prudent and sanitary to use them. Glove use may or may not be required by your workplace policies. Some general administration safety tips are regarding personal and facility considerations. Some personal considerations would be the wearing of a face mask by both vaccinators and patients, washing hands and cleaning patient care areas between encounters, using eye protection and face shields when necessary, and wearing those gloves when administering vaccines, making sure to change gloves between each patient. Some facility considerations would be to screen patients for COVID-19 symptoms or any recent known contacts with COVID-positive persons, limiting and monitoring the entrances into the facility, creating barriers to limit unnecessary patient contact during triage function, having patients remain outside until they're called into the facility when possible, and maintaining the social distancing space of 6 feet apart using barriers and signs. Lastly, using electronic communication to minimize patients' in-office time, as well as reducing touch contamination of supplies like pens and clipboards. Now I'd like to talk about the EUA fact sheet, which provides vaccination information to patients. We may be used to providing the Vaccine Information Statement, or VIS, to patients receiving vaccines. However, there is no VIS for the COVID-19 vaccines, which are authorized under the Emergency Use Authorization. Instead, the FDA issues the EUA fact sheet for recipients and caregivers. So, as the vaccination provider, you must communicate information consistent with the fact sheet to patients, as well as provide a copy or direct patients to the fact sheet prior to administering the COVID vaccine. I've placed the links below for each available vaccine manufacturer website where you can find the fact sheet. Next, we will discuss injection technique. While the outer edge of the thigh may be used for intramuscular injection of children, according to ACIP recommendations, the deltoid muscle is the preferred location for intramuscular injections for those 3 years of age and older. So the deltoid muscle is the preferred location for IM injections. It's recommended to use the non-dominant arm, however, that's not a strict rule. You should be injecting into the deltoid muscle of the upper arm slightly above the level of the armpit and below the acromion, which is the bony tip of the shoulder blade within the upper arm. This positioning is important because of what we don't want to happen, and we don't want to have something called SIRVA, or shoulder injury related to vaccine administration. This happens when the injection is delivered into the shoulder capsule instead of the deltoid muscle, and this can occur when you inject too high up or out of place. SIRVA can lead to pain, decreased range of motion, decreased quality of life for patients, and the symptoms can begin within 48 hours and can persist for weeks to months. Needle gauge length and insertion are also important. A 22 to 25 gauge needle is recommended. The length of the needle depends on the weight and sex of the patient. Generally, the larger the patient, the longer the needle you should use, up to 1.5 inches. Children can be injected with a 5/8 to 1 inch needle. So can lower weight adults. Those at higher weights, such as greater than 260 pounds, males or females, should require a 1.5 inch needle. However, females at or above 200 pounds should also require a 1.5 inch needle, possibly because of increased fat mass and less muscle mass in females. The injection should be inserted into the muscle at a 90-degree angle, as shown in the diagram, and pulling back on the syringe plunger is not necessary before depressing the plunger to release the vaccine into the muscle. I have here the steps of intramuscular administration, and they include the washing and sanitizing of hands, applying gloves per policy of your organization, preparing the vaccine dose in a syringe if not already prepared, cleaning the injection site of the deltoid muscle with alcohol and allowing the area to dry, inserting the needle into the muscle at a 90-degree angle and depressing the syringe plunger, removing the needle and activating any necessary safety mechanism. Safely dispose of the needle and syringe unit in a designated sharps container. Apply moderate pressure to the injection site with a cotton swab, and then apply a bandage to the site afterwards. Also remember to remove gloves and wash or sanitize hands between patients. And just like that, you have administered the vaccine. I'd like to switch gears a bit and discuss the administration of secondary doses and boosters. This is because considerations must be made for secondary doses and boosters prior to or at the time of a first COVID-19 vaccination dose. Let's take a look back at primary series dosing for each of the COVID-19 vaccines. Just to review, we currently have 3 vaccine manufacturers distributing in the U.S., Pfizer, Moderna, and Janssen or Johnson & Johnson. The Pfizer vaccine comes in 3 different presentations. Pfizer manufactures the only vaccine products that can be given to children and adolescents from 5 to 17 years of age. For primary series dosing, all Pfizer vaccines are to be given in 2 doses 21 days apart, regardless of the formulation. The orange vial cap Pfizer vaccine is indicated for children 5 to 11 years of age. The purple or gray vial cap formulations are indicated for adolescents starting at 12 years of age as well as adults. Remember that gray cap presentation does not need to be diluted, but the other 2 do. The Moderna vaccine is indicated for adults 18 years of age and older. For primary series dosing, is given in 2 doses 28 days apart. The Johnson & Johnson vaccine is also indicated for adults 18 years of age and older. For primary series dosing, this one is a 1-dose regimen. Now, there are some specific recommendations regarding immunocompromised individuals, and for all patients receiving Pfizer vaccines as well as Moderna vaccines for their primary series, it's recommended that they receive an additional primary dose at least 28 days from their last dose. But this recommendation does not apply to the Johnson & Johnson vaccine. Because of the 2-dose series mRNA vaccines given at a specific time frame, it's very important to manage vaccine inventory and doses. The goal is to optimize the number of persons receiving first doses while ensuring access to second doses. How does one go about doing this? Well, as you administer first doses, you should be able to estimate the number of patients that will require a second dose every week. Patients requiring the second doses should be prioritized. However, missed appointments should be reviewed consistently, and the remaining doses should be repurposed or recategorized as first doses for new patients. Second doses should definitely not be held or saved for patients who have not returned after 42 days past their first dose. It's a good idea to schedule second dose appointments at the time of the first dose and provide patients with reminders via electronic and physical means, which we'll review shortly. We should be giving the second dose as close to the recommended interval as possible. However, if the second dose is given beyond the recommended interval, there's no need to restart the series. Of course, with the combination of vaccine products, different expiration dates, and storage requirements, as well as variable dosing schedules, inventory management is important to avoid wasting vaccines. Unfortunately, vaccine waste is sometimes unavoidable. Some tips to avoid wasting vaccine are to monitor your expiration dates, making sure you use the closest expiring stock first. Another tip is to only take out what you need. Some of the vaccine products are stable for longer. Really, all of the vaccine products are stable for longer at colder temperatures. So only unfreezing or bringing to room temperature those vials that you need immediately and leaving the other ones frozen or refrigerated may be a tactic to avoid wasting doses. Also, following the recommended storage and handling guidelines and monitoring vaccine storage unit temperatures will help to ensure the vaccine viability. Having a vaccine wait list was a common way in the beginning of the pandemic vaccination effort to ensure that patients could be called in to receive doses that would otherwise go to waste. But as vaccine demand decreases, this is less of an option. Some other tactics are to have a backup power supply to maintain vaccine cold chain storage requirements, and to educate all staff handling the vaccine on the proper procedures to ensure vaccine potency and patient safety. Now, many people have questions about early or late administration of second doses. So, can patients take a second dose of the COVID-19 vaccine early? The answer is yes. Second doses administered no more than 4 days earlier than recommended are valid. Now, if you so happen to administer a second dose earlier than the 4-day grace period, you don't have to repeat any dosing, but this is strongly discouraged. It's strongly discouraged to schedule folks with the 4-day grace period. We are supposed to be scheduling on the actual recommended dates. Now, on the converse, what if you have a patient who misses their appointment for their second dose? Okay, what if it's a late time? The answer is that you can administer a second dose of either mRNA vaccine up to 6 weeks or 42 days after the first dose. When it comes to second dose reminders, we have to consider reminders for ourselves, the vaccination providers, as well as reminders for the patients. Some ways to remind ourselves are to put reminders in the electronic health record system as an alert. You can also cue vaccine prescription labels to print near the patient's return date. You could do something like maintain an electronic spreadsheet, like an Excel spreadsheet or some other type of database. You can also use an electronic or physical calendar to mark when patients should return. Another option is to use note cards or sticky notes as reminders, but this may not be best because they could get lost. We also have to account for this in our staffing models because some staff will need to be assigned to patient follow-up. As far as patient recall reminders, one reminder could be the patient's vaccination record card or a handout given during the first dose administration, which tells them when they should return. Telephone calls and text messages are effective reminders for patients. Another option is the vSafe application from the CDC. We'll discuss that more in part 3. You can send patients reminder emails or set up alerts from the electronic health record if possible. You can also send letters, mailers, appointment cards, but when mailing anything, you must be sure to protect the patient's confidentiality. So we need to remember confidentiality if we're going to mail anything. As we know, it is now recommended for the vaccinated to receive COVID-19 booster doses. Booster doses are now recommended for all patients 12 years of age and older, although only the Pfizer vaccine is authorized for adolescents from 12 to 17 years of age. Booster doses are recommended at least 5 months after receiving the last primary dose of an mRNA vaccine, so that's Pfizer or Moderna, and at least 2 months after receiving a primary dose of the Janssen or Johnson & Johnson vaccine. 1 booster dose is currently recommended at those time frames, and an important note to point out is that the booster dose of the Moderna vaccine is actually half of the primary dose at 0.25 mils instead of 0.5 mils. Otherwise, the doses and dose volumes are identical to primary dose volumes for the Pfizer and Johnson & Johnson vaccines. Another important note is that the CDC recommendation is to use an mRNA vaccine for booster doses due to increased efficacy of those over the Janssen vaccine. It's still up in the air as to whether additional booster doses will be recommended on an annual or semi-annual basis for coronavirus. So we will see. I'd like to now discuss interchangeability of COVID-19 vaccine products. There is no preferential recommendation for the primary series, so that means any of the 3 currently FDA approved or authorized COVID-19 vaccines can be used when indicated. In general, it's recommended that all primary series doses and additional primary doses should be with the same vaccine product or manufacturer. However, when it comes to booster doses, mixing and matching is allowed for adults. So adult patients that originally received Pfizer vaccines for primary dosing could receive a Moderna booster vaccine and vice versa. But remember, adolescents are only able to receive the Pfizer vaccine, so they cannot mix and match at this time. Now, it was previously recommended that COVID-19 vaccines be given 14 days apart from other vaccines, but that recommendation has changed, and COVID vaccines can now be administered without regard to the timing of other vaccines, so you can schedule them and administer them on the same day as other vaccinations. If you're going to do this, as usual, when multiple vaccines are given in the same visit, you should use different injection sites for each vaccine. This can mean placing the injections as little as 1 inch apart, or placing one injection into a left arm and the other into a right arm, which is what I would recommend. You should definitely use that method if you have reason to believe one of the vaccines is more likely to cause a local reaction. Let's move into our last major section for this presentation, which is clinical considerations for specific and vulnerable groups. I have here a photo of the Louisiana COVID-19 vaccine eligibility timeline. And if you remember, we had a phased rollout by which the COVID vaccines were released to the public. The rollout was actually based on the National Academies of Sciences framework for equitable allocation of the COVID-19 vaccines. And it considered things like age, certain health conditions, living and workforce categories. So priority was given to those most at risk of harm or adverse outcomes. I'd like to discuss contraindications and precautions to COVID-19 vaccination. Now this can be somewhat confusing, so we'll take a look at each of these categories, starting with the red section, which is a true contraindication. A COVID vaccine would be contraindicated if a patient had a history of a severe allergic reaction, such as anaphylaxis, after having a previous dose of a COVID vaccine, or a severe allergic reaction to any component of a COVID vaccine. It's the same situation if a patient has a diagnosed allergy to a component of the COVID vaccine. So you should not vaccinate these patients with the vaccine they are allergic to. However, you might consider vaccinating them with the alternative COVID vaccine when appropriate. So basically, people with a contraindication to one of the mRNA COVID vaccines should not receive any other mRNA COVID vaccine. So if you had a very bad reaction to the Pfizer vaccine, then you should not receive another dose of the Pfizer vaccine, nor should you receive a dose of the Moderna vaccine. However, you might be able to receive the Johnson & Johnson vaccine after a detailed risk assessment and possible allergy testing by an allergist immunologist. The next category of patients would be those who have a precaution to COVID-19 vaccination. These people may have had an immediate, mild, or moderate allergic reaction to a prior COVID vaccine or to any other vaccines or other injectable therapies. These reactions would have been non-severe and non-life-threatening. And in this case, a risk assessment should be done and considerations could be made for COVID exposure possibility, adverse outcomes risk, and also the location where the vaccine is being given and the availability of emergency medical assistance if it's necessary. And in these cases, the case of precaution, the COVID-19 vaccine may be given with a 30-minute observation period. The last category of patients would be those who have no contraindications or precautions to COVID-19 vaccination, and that's the green section. So patients who have allergies to any other substances such as medications, foods, animals, environmental allergies, or who have a family history of allergies should be fine to receive the COVID-19 vaccine. Even patients who have had an anaphylactic reaction to any of those things I just mentioned are still eligible to be vaccinated, but they will require a 30-minute observation period post-vaccination. Unlike some other vaccines, the COVID vaccines do not contain eggs or gelatin, which some people are allergic to. The vial stoppers also do not contain latex, which some people are allergic to. So all other patients with no known allergies, as well as those with existing mild to moderate allergies, should be observed for 15 minutes post-vaccination. So we see that a majority of patients can receive the COVID-19 vaccines, and these severe reactions remain extremely rare, but what happens when something goes wrong? Let's remember how to recognize anaphylaxis. We should consider anaphylaxis when the patient presents with generalized symptoms such as widespread hives or severe life-threatening symptoms, or symptoms that involve more than one body system. If we were going to do a review of systems for the respiratory system, we might recognize shortness of breath, coughing or wheezing. For the GI system, there could be nausea, vomiting, diarrhea, abdominal pain. For the cardiovascular system, we may see dizziness and fainting, tachycardia with hypotension. On skin, we may see the generalized hives as well as itching or swelling of the lips, face, throat. Neurologically, the patient could show an acute change in mental status or have that sense of impending doom. They may be agitated or even begin to have convulsions. So you see the signs. It's time to jump into action. You have been prepared to act fast because time is critical when someone's experiencing an extreme reaction. First, quickly assess their airway, breathing, and circulation. Epinephrine should be available, preferably in an auto-injector. And you should administer the epinephrine immediately by firmly pressing the injector into the middle of their thigh muscle. And you can repeat this process within 5 to 15 minutes. Most patients are going to respond to the 1 or 2 epinephrine doses given this way. A member of the team should also call emergency medical services, and you should place the patient in a supine position, laying down with their legs elevated. Continue to monitor the patient until help arrives. You should be prepared with a blood pressure monitor and a pulse ox device. Other drugs to have on hand would be antihistamines such as Benadryl and even a bronchodilator like albuterol. Now that we've handled that crisis, let's talk more about some specific and vulnerable groups. Many patients who have already had COVID do not believe they need a COVID vaccine. However, COVID-19 vaccination is recommended for everyone 5 years of age and older, regardless of a history of symptomatic or asymptomatic COVID infection. There used to be a recommendation to wait 90 days from prior COVID infection to receive a vaccine, but that has changed. The CDC now recommends deferring vaccination only until recovery from acute illness if symptomatic, and whenever the criteria to discontinue isolation has been met. So, once a patient is fully recovered and is out of their isolation time frame, they can be vaccinated with a COVID-19 vaccine. There are also patients who receive the available monoclonal antibody therapies for COVID-19 treatment or post-exposure prophylaxis. For those patients who receive COVID antibody therapy for post-exposure prophylaxis, they should defer vaccination for 30 days. For those who receive COVID antibody therapy for treatment of diagnosed COVID, they should defer vaccination for 90 days. And this is to avoid potential interference with the product and vaccine-induced immune response. Speaking of immunity, let's continue with the vulnerable groups of the immunocompromised. Patients who are immunosuppressed or have autoimmune disease are actually at increased risk for severe COVID-19. Some examples would include cancer patients actively being treated for malignancies, patients who are post-solid organ transplant and taking immunosuppressive therapies, or patients with stem cell transplants, those with moderate or severe primary immunodeficiency, patients with advanced or untreated HIV infection, and patients receiving other immunosuppressive therapies, including high-dose corticosteroids greater than or equal to 20 milligrams of prednisone per day for 2 weeks or more. And there are some other drugs possible. These patients may not mount a protective immune response after their initial vaccinations, and their protection from their primary series may wane over time. For this reason, it's recommended that they receive an additional primary dose of an mRNA vaccine 28 days or more from their last primary dose. Now, these patients are also recommended to receive their booster dose 5 months or more from their last dose, scheduled to receive 4 doses basically. Immunocompromised patients who receive 1 primary dose of the Johnson & Johnson vaccine are not recommended to receive an additional primary dose. However, they should still receive a booster vaccine dose as early as 2 months from the primary dose, and preferably with an mRNA vaccine. I'd like to reiterate some of the points regarding children and adolescents. Children and adolescents from 5 to 17 years old are recommended to receive the age-appropriate formulation of the Pfizer COVID-19 vaccine. This is not weight-based dosing, it's only dependent on age. So children 5 to 11 years old should receive 2 doses of the orange cap formulation. Adolescents 12 years of age and older should receive 2 doses of the purple or the gray cap formulations. Children and adolescents that are immunocompromised need an additional primary dose of vaccine 28 days from their last primary dose. And adolescents 12 years of age and older are currently eligible to receive a booster dose 5 or more months after their last dose. The last group I'd like to discuss are those with pregnancy, lactation, and fertility concerns. The bottom line is that COVID-19 vaccination is recommended for people who are pregnant, lactating, trying to get pregnant now, or who might become pregnant in the near future. Although the CDC says that overall risk is low, pregnant and recently pregnant women are at increased risk for severe illness from COVID-19. Also, pregnant women with COVID are at increased risk for preterm birth, stillbirth, and possibly other pregnancy complications. As time passes, there's more evidence on the safety and effectiveness of COVID vaccines during pregnancy, and the data indicates that the benefits of vaccination outweigh the risks. It should be noted that all women less than 50 years old should be aware of the rare risk of TTS with the Johnson & Johnson vaccine, but we will discuss this more in Part 3. There's currently no evidence that any vaccines, including the COVID-19 vaccines, cause fertility problems for women, according to the CDC. I have included here some resources for more information. In particular, numbers 1, 2, and 3 will give further details on the topics we discussed in this presentation. Thank you for your attention. If you have any questions, please post in the discussion board. And that concludes our presentation, Part 2, for Module 8. Thank you.